Over the past 30 years, antidepressants have come to be amongst the most prescribed medications in Canada. For those who have been helped by them, their worth is indisputable. Yet there is much that remains unknown about them, including the finer points of how they work or don't. Joining us now on the Science of Antidepressants, from Stanford, California, John Ioannidis. He is director of Stanford University's Meta Research Innovation Center. And here in our studio, Dr. Tamina Eapen, lecturer at the University of Toronto and a psychiatrist with CAMH, the Center for Addiction and Mental Health, and Dr. Sydney Kennedy, the Arthur Summer Rotenberg Chair in Suicide and Depression Studies at St. Michael's Hospital and a professor of psychiatry at the University of Toronto. And we are happy to welcome you two here, and to John in California. We're so grateful that you were able to be with us as well, where, as we can see in the background, it's still daylight. Let's bring up some, I guess, background information here that just will help set the table for our discussion to come. Canada has some of the world's highest rates of antidepressant use. Between the years 2012 and 16, antidepressant use in children and youth increased by 63%. And the majority of these drugs are called SSRIs, selective serotonin reuptake inhibitors. And I guess I want to start, John, we'll go to you in California first. I'd like to know how confident you are that these antidepressants that so many of us apparently are on are actually effective at treating depression.
So I think that we have substantial evidence to have a fair statement that antidepressants work on average for adults. And we are pretty confident that the average benefit that you would get from an antidepressant is likely to be small or modest. What that means is that very large benefits are pretty uncommon. It also means that there are several people who would not benefit from an antidepressant. And also, we have to qualify that statement with saying that these are data that pertain to adults. So when it comes to children and adolescents, probably the picture is very different. The efficacy is less, or even the balance of benefits and harms could be very, very different, and maybe in the vast majority of cases, they would not be indicated.
Tamina, a follow-up if you would. How confident are you that these drugs actually do what we think they're supposed to do?
So what I'm not hearing in any of these articles or in any discussion is also, how good are we at diagnosing depression? So I'm not confident that when I meet a patient with a label of depression, that they in fact have a biological clinical depression that would respond to a biological intervention.
As opposed to just being sad because they got some bad news.
Well, yeah, I mean, I don't want to minimize their experience, but we are not as adept at confirming a diagnosis in mental health as we are in other fields of medicine. And without being much more confident about the actual phenomenology of what we're dealing with, I think it seems like we're not really addressing the whole issue. Just because someone is sad doesn't mean that a pill is going to solve the sadness. Right. And it's not that simple, which is why, I mean, we've been dealing with the same molecules for almost 60 to 100 years. So that tells us something about how limited we are in research, which I think is also limited by the fact that diagnostic clarification is so difficult in psychiatry.
Sydney Kennedy, where are you on this?
Well, I'm confident, based on patients that I've treated over a number of decades, that there are people who do extremely well and antidepressants put them back in everyday life. I'm also unfortunately aware that others are only minimally helped or not helped at all. And of course, I don't think it's restricted to antidepressants. It also applies to different psychological treatments, neurostimulation treatments, many of the other options that we have. But I think it's important to pick up on the last point, that we really don't have a diagnosis that we can hang our hat on in terms of a particular test or marker to say you have an elevation of substance K and therefore you're in the depression group. So it's not a surprise really that with the lack of ability to identify an individual medication or psychotherapy linked to a particular disruption in brain function, that we don't do a very good job in getting more people better, certainly on the first or second attempt.
Tamina, can you tell us how they actually work?
Which class? So there are different classes of antidepressants.
Let's go back to the SSRIs,
Sure.
which we referred to earlier, and
Sure.
we know what they're supposed to do.
Yes.
Without drowning us in too much science, how do they actually work?
Well, I think it's just better to understand it in basic terms. So we're trying to increase serotonin, which is a neurotransmitter in the brain associated with improved higher moods in different parts of the brain. And so it blocks the reuptake of an inhibitor. So we're trying to increase its availability to different parts of the brain, and then that has corresponding effects on other neurotransmitters as well. So we want people to have higher rates of concentration, better ability to focus, decreased distractibility, hopefully some kind of regulation of a sleep cycle, these kinds of things. But again, we don't have exact measurements of concentrations of serotonin in different parts of the brain. And depending on our genetic makeup, we're all going to respond to these medications differently.
In which case, let me follow up with John. Based on your experience in this field, what percentage of people will react the way you would like to or hope that they would react if they take these antidepressants, and what percentage of the population are they just not going to do anything for?
So again, if we limit to adults and people who have a diagnosis of moderate or severe major depression. So these are not the people who are just sad for a few days or just had something bad happen to them, but they have a clear evidence of being severely depressed. If we give them placebo, about a third of them would respond, 35% of them would respond. If we give them an antidepressant, anywhere between 42 to 53%, depending on what antidepressant we're talking about, would respond. So there's an extra incremental benefit on top of that 35%, anywhere between 7% to 18%.
Can I just jump in there for a second?
Is it half empty?
Well, that's what I wanted to ask. I mean, given the billions and billions of dollars that are being spent on these medications, are you telling us that we're really only getting a potentially 7 to 18% bump over a sugar pill?
That's pretty much what it is. And some people may argue that it's not enough. But again, you have to take into account that there will be quite a bit of individual variability. So as I said, there will be lots of people, as it was mentioned earlier, who will not get any benefit at all. And there will be others who will get far more benefit. So let's say if I had to make a personal choice, and if I had severe depression, probably I would like to try an antidepressant, not with the hope that I would get the average response, which probably would not be really that big, but with the hope that maybe I would belong to that tail of relatively fewer patients who may get a bigger than average response. So clearly, we don't have an optimal treatment. We have one treatment, actually a number of drugs that may be offering some benefit, but it's not for sure that it will work for everybody.
Okay, Sydney, again, part of the education of the host here. I understand that there are SSRIs, which we've been talking about, and that is one kind of antidepressant, right. And there are other kinds as well. What's the difference?
Well, the oldest drugs for the treatment of depression were really developed by coincidence in the 1950s. So we have tricyclic antidepressants, two of which were actually included in Professor Cipriani and Ioannidis' recent landmark study, drugs amitriptyline and clomipramine. But I think with the beginning of the Prozac era and the SSRIs, people had tremendous optimism. Then we recognized that if you could actually block norepinephrine or noradrenaline, as well as serotonin, that had certain potential benefits. So that led to the class we call SNRI. So that's both serotonin and norepinephrine. And some of the agents will also act on dopamine. So we have a number of transmitters. I think the honest answer to about how antidepressants work is we don't know. We know in the test tube, we know in certain lab conditions how they change chemical signaling. We even know from brain imaging studies how people, even after one dose of antidepressant, can have different imaging profiles. But in terms of the efficacy, I think the answer to we have the answer from the recent Cipriani that most antidepressants are similar, but there are certain differences in terms of the acceptability or tolerability, and some differences in the superiority over placebo.
Let me follow up with Tammin on this, because I know every time we've had brain scientists come on this program and I say, how much do we know about the brain on a scale of 1 to 10?
Yeah.
Most of them say something, well, we're about a 1 or a 2 right now.
Right.
So I get that, but having said that, how is it that all these decades later, we still really don't have a good sense about why or how these things work?
So I'm not a researcher, but what I can tell based on my clinical experience is that we're limited in research in mental health for many reasons. For my father, who's an oncologist, has no shortage of patients who want to participate in trials to potentially help their cancer. In mental health, that's quite difficult. Even treating some of my patients is a challenge. By definition, the organ which gives us awareness is also compromised in their illness. So I think there are many, many limiting factors here, including the ethics of trying to get people who are compromised to basically be an experiment.
Okay, John, let me bring you back into the conversation to find out more about a study on antidepressants that you did. And one of the things I gather that you looked for in your study was something called publication bias. Now, as we sort of drill down on what the study was about, let's start there. What is publication bias?
So publication bias is a major problem in clinical research, and it has been speculated that it may affect different types of clinical trials, including antidepressants. Practically, what happens is that trials that get negative results, not favorable results, might disappear, and only those that have positive results would be published. And if this were to happen, you would get a very distorted picture in the literature, because the drugs would seem to work, but actually this will just be the fact that the negative results are not available to be included in the calculations.
Okay.
So for many years we have been speculating how extensive publication bias is in the case of antidepressants, and we do have some evidence. For example, when we have the opportunity to compare the submission of results to regulatory agencies like the US Food and Drug Administration versus the published literature, it has become evident that the trials that get published, almost all of them have nice-looking, quote-unquote, positive results, but actually the study results that are submitted to the regulatory agencies, some of them have positive results and others have negative. And what happens is that the negative results either don't get published, or actually more commonly, they are reanalyzed in a more creative way so that they may look to be, quote-unquote, positive as well. In the case of the recent meta-analysis, where we combined data from 522 trials, we did our best to try to unearth unpublished data, so try to avoid publication bias as much as possible. And I think that we got a lot of them. It's impossible to get all of the unpublished data, and it's impossible to be sure that there's not more. So I think that we probably improved the picture of the evidence in terms of its reliability. We tried also to assess whether there are some other hints of bias in that corpus of information. And what we detected is what is called novelty bias. Novelty bias means that if you have a new drug, it looks very nice, but when it becomes older and it's compared against newer one, it loses some of its nice-looking picture. And it's still the same drug. Why is that? Well, it could be a similar type of bias. It could be expectations, it could be manipulation, it could be marketing, it could be the allure that something is new. So both of these types of biases could have an impact on the results. So whenever you see some measure of efficacy, maybe you need to downgrade it a little bit, or maybe more if you're more skeptical, depending on how big you think that publication bias might be.
Okay, that's helpful to our understanding of this. And Sydney, let me get you to follow up with this aspect of the story then. People take these antidepressants, some people do, for a very long time. Some of them are on them for years and years and years. Do we yet have a good understanding of the impact on the mind and the body of someone who's on these things for years?
Well, I think we probably could identify people who've taken even some of the first-generation antidepressants for more than 30 years, and they've actually been helped significantly. The issue really is that registration of a new antidepressant, certainly through FDA, or Health Canada through the Food and Drug Administration
in the States,
really requires short-term hurdles to be passed. So perhaps 3 consistently positive trials would be enough over 8 weeks. That's really not giving information about the long term. So there are some other agencies that would require at least a 6-month what might be called a relapse prevention design, where people have all responded. Some are switched to a placebo, some stay on the active drug, and you look at whether the drug continues to provide an advantage. And there's fairly robust evidence, indeed, from one of Dr. Ioannidis' colleagues, John Geddes, who's also on the Cipriani paper, of the success of maintenance treatments. So I think the issue is a complicated one. People have a sense that they would be better to not take antidepressants over the long term, so they would like to come off them. There's no doubt that there are drug discontinuation, or what some people would call withdrawal effects, particularly if you do it too quickly.
Sure, let me pick up on that, because John, I'm sure you saw the front page story in the New York Times yesterday, which was really quite significant in detailing for many people who have been on antidepressants for many, many years, the difficulty they have withdrawing from these drugs and how their lives are, really quite messed up, given the consequences of trying to get off the medication. It's almost, I think some of them said, worse than the original depression that they were dealing with in the first place. What do we do about that?
So I think that we have to be very cautious. We do have some evidence on long-term use of antidepressants, but it's far more limited compared to the evidence that we have on acute use. So the recent Lancet paper where I was involved included only trials that had looked at 8 weeks of follow-up, more or less. This is the acute setting. It says nothing about what would happen in the longer term. There are some trials that have looked at the longer term. There are not 522 trials like the acute phase. And obviously, as you realize, the people who stay on board for these trials are even more selected. Some of them perhaps would indeed get benefits, and others would probably have a very hard time using these drugs, and even more so trying to get off these drugs at some point. We just need more evidence on long-term follow-up, and I would argue that eventually we're not treating depression just to get a quick response within a few weeks and satisfy our curiosity of improving some of the depression scales like the Hamilton scale. We're doing it because we want these people to be functional and have lives that they enjoy in the long term. And that means that the outcomes that I would like to see captured in clinical trials for depression would be things like depression leading to suicide or suicide attempts, loss of job, marital problems, divorce, things that do really matter rather than just a scale that can be assessed in a quick and dirty manner, but is very rudimentary.
Okay, Tamina, I want to ask you about your practice, okay?
Okay.
Somebody comes in, meets you, prospective patient,
Yes.
says they're feeling depressed.
Yes.
How do you make the assessment? I guess on what criteria do you make the assessment on whether or not this patient is a good potential candidate for antidepressants or not?
Right. I'm first going to mention that I look after 95% of my practice is people admitted to hospital against their will. So it's already a different subset of the psychiatric population.
So in almost all your cases, medication is
warranted.
Advised.
It is advised. But having said that, it's also my responsibility to rule out other medical presentations that can mimic a biological depression, if we're talking about depression. I also have to be considerate of other diagnoses which include depression as part of its diagnosis, for instance, bipolar disorder. And so I have to be very careful not to initiate an antidepressant without posing a risk of inducing mania as well.
That's a lot of responsibility, actually, isn't it?
It is, yeah. I'm lucky I'm here today. Yeah. So along those lines, so once I'm trying to be confident about ruling out macromolecular causes of depression, which is the way I like to frame it. So
Which
if
means
there's
what?
like a tumor in the brain or an abnormality with hormone disturbance, those kinds of things. Once I've ruled out those contributing potential factors, then I also want to know about family history, because that's often our greatest genetic clue in psychiatry.
Your parents had it, chances are you might too.
A first-degree relative, and have they been diagnosed by a professional who's qualified to make that diagnosis? And what treatment did they also receive? These are all helpful factors. Then there are different types of depression. So if people are agitated or more lethargic, then that also influences the type of molecule I'm likely to choose.
Well, let's hone in on the 5% who are not in care against their will.
Yes.
The 5% who sort of volunteer to walk through that door because they think they need help.
Right.
What percentage of them would you put on some kind of SSRI?
Those people, I think, require a very thorough evaluation. And I think we need to be open also to the possibility that they don't meet the threshold for biological clinical depression.
So what the symptoms they present are not extreme, if I can put it that way.
They may or they may not be. So in mental health particularly, we rely on self-report. Because I don't have a biopsy or a radiological image to verify, we do rely on what people say. So people will often come in and see me and tell me they're depressed, and I remind them, I'll decide if you're depressed. Please tell me what your experience is. What's your life like?
Are they offended when you say that
Frequently.
to them? They are?
Yeah. But then I remind them that they're not telling their cardiologist what their illness is either.
Very good.
Yeah.
Very good. It's another reminder that we ought not to sort of hive off mental illness from oncology or cardiology or all the other ologies.
The other thing I'd like to say is that bread and butter psychiatry, particularly in large urban centers, is looked after by primary care physicians. So the last time I saw what we call a minor depression or generalized anxiety disorder that didn't cause tremendous functional impairment was as a resident a few years ago.
Okay.
So much of that burden is relegated to people who don't have as much training as I do.
And let me do one more question with you here, which is, I presume when you come to the conclusion that yes, some kind of antidepressant is advisable here to help this person with their depression,
Yes.
you then have to figure out, well, do they need a lot or a little or a medium amount? How do you figure out dosage?
Well, there are algorithms to follow, and there's a product monograph, and we start at very safe doses to begin with. It also depends on the frequency of follow-up. So if I can see someone fairly regularly, I'll probably be more aggressive depending on the severity of their symptoms.
But at the end of the day, is it trial and error?
It's a lot of trial and error and a lot of trust. Yeah.
Gotcha. John, I want to go back to you because I think numerous times we've heard during the course of our conversation here tonight, here's what we know about adults. We're leaving kids out of the mix for now. Okay, I don't want to leave kids out of the mix any longer. So let's focus on them for a second here. Is there enough research out there to know how the developing brains of children and teenagers can have an impact on the decisions that have to be made on how to treat their mental illness?
If I had to answer yes or no, I would probably say no. And I think that we have to be very, very cautious with children and adolescents because we have come across nasty surprises in the past with documented clinical effects, even for the outcomes that I was mentioning earlier as being the ones that we really need to look after. So even having evidence for increased risk of suicide with use or misuse of antidepressants in kids and early adolescents. So I think that for this population, we have to be extra cautious.
And, well, you say extra cautious, and Sydney, I'll point out what I said right off the top. Between 2012 and 2016, antidepressant use in kids and youth increased 63%. That sounds like either there is a massive new understanding of depression in children and youth, or we're medicating the hell out of kids because we don't know what else to do.
Well, let me say first and foremost, I'm not a child psychiatrist or child or adolescent, but I think those figures need to be taken in the context of what happened before 2012. So there was a, quote, black box warning. As John referred to, there were issues about the initiation of antidepressant treatment in children, and particularly the increase in suicidal ideation. So there was a massive pullback, I think, in prescribing antidepressants to kids. Many child psychiatrists really were in a very difficult position as to how to handle, and even if you said cognitive behavior therapy is as good, there were not adequate resources to support enough therapists. So I think probably part of what you're describing is a rebound effect as people realized that with proper support and care, they could use antidepressants in children. But again, I want to slightly take exception to my colleagues' comments about the word biological depression. The brain is a biological organ. If I have a stressful event that causes me to have disrupted sleep for 2 or 3 days, I have biological consequences that may respond, just remit spontaneously, or I may need some stress reduction, if you like.
I don't want to speak for your colleague, but I
Yeah.
presume you meant when you said that
Yeah.
depression that is not brought on by events, but rather by some chemical change in the body absent events.
But Steve, that's the events react with the body and the brain. So we're not talking about either or.
So you don't want to make that distinction, is what you're saying.
I just think it's not a correct distinction.
Tammany, you want to come back on that?
And it is an oversimplification for sure, but I think there is a tendency to, there will be biological consequences if we are upset. We can measure all kinds of hormones in our blood, et cetera, et cetera. So that's true. I guess my concern is that we believe that the administration of, let's say, an SSRI can have a greater impact than it sometimes can without considering other very important factors such as psychotherapy, human connection, a sense of purpose in our life, which also has biological impacts on the brain. So when I say biological, what I mean is we have to look at this from a multifactorial perspective, whereas there is a subset of the population which responds really well to a medication treatment approach alone.
Gotcha. John, can I get your take on why you think the numbers have skyrocketed so much in terms of medicating kids with antidepressants over the last half decade or so?
I think that it could indeed be a rebound effect, but I would also worry that there's a lot of overuse and inappropriate use. When it comes to antidepressants, I think it's a huge market. It has been a huge market for many decades now. And if I were to take a random sample of people from the population using antidepressants, probably the majority of them don't need them, or maybe they could have tried something else with a better effect, or maybe they don't need anything at all of all the options that we can offer them. This doesn't mean that there are not people who are not under-medicated and who would benefit and have not tried. So I'm sure that there are several people with severe major depression that are very reluctant to try any treatment, and some of them would have seen some clear benefits. So we have both underuse and overuse, but I think that overuse is probably a more prominent problem compared to underuse.
Sydney, can I get you to weigh in on that scale? I'm mixing my metaphor there, but whether antidepressants are overused or underused?
Well, I think we all recognize that depression is now the #1 cause of global burden of disability. The US figure cited in Cipriani is $200 billion a year, and 50% of that is workplace-related, either absenteeism or what we call presenteeism.
Sorry, so the $200 billion refers to?
Healthcare costs, death by suicide, but 50% of it is underperformance or absence in the workplace. So it's no secret that the major insurers are all struggling to do a better job to treat depression. So I'm not sure that it's either under or overutilization, it's the accurate identification of the individual and the right treatment for that individual that is really the struggle that we're all pursuing.
Tammin is nodding here.
Absolutely.
You agree with that?
That's the key. I don't think we can know if it's more or less, but we need to do a better job of understanding our patients and having access to resources such as psychotherapy as well.
Okay, patients obviously deal with the gatekeepers of the healthcare system, meaning family doctors first, and then I guess if necessary, they go to a psychiatrist after that. Is that basically how it works?
That's the dream. Yeah.
That's the gist of it. Okay. How often are antidepressants given out at that first stage by the family doc versus the psychiatrist at the second stage?
Frequently. They're already on a treatment.
So by the time they get to you, they may be already on medication.
Yes.
Is that okay? Is that the way it should be?
I don't know if it's a question of should. I think that when a patient presents to a physician's office in a great deal of distress, it's probably very difficult to hold off, especially since there can be very lengthy wait times for them to see a specialist.
Do you think general practitioners are adequately trained / equipped to make that conclusion after, presumably on the first visit, and therefore prescribe that kind of medication?
I think they're limited by their time. So if I had 15 minutes to make a diagnosis, I would be hard-pressed to be confident in the accuracy of that diagnosis. I also don't think they're supported adequately. It's not like diagnosing hypertension where they can measure that. This is something that needs to be looked at over time, and again, in more than 15 minutes.
Sydney, what's your view on that?
Well, I think about 80% of antidepressants prescribed, for example, in the province of Ontario, are prescribed by family doctors.
80%?
Yeah. So I don't think the psychiatry resource would be able to cope if every patient had to see a psychiatrist to get a medication. I think there's some truth in the fact that time is a major issue in the primary care setting. And it would be nice to think that in the absence of an acute risk, suicidal risk, that somebody could come back, there could be a bit more reflection. But I think that family doctors, by and large, do a very good job. They understand there's lots of educational events that they attend. Many specialize and have a practice that focuses on mental illness. So I think by and large they're doing a good job in prescribing antidepressants.
Let me get John on that. If you knew that 80% of the antidepressants that were being prescribed were being done so as a result of a single 15-minute interview between family doctor and patient, how would you react to that?
I think it is problematic because obviously, as we have already discussed, making a proper diagnosis of depression is not an easy thing. And for a family doctor within a few minutes to make that diagnosis, it's even more difficult. So it's very likely that many of these prescriptions are not appropriate. Now, is that completely horrible, or is it okay to just take a shot and see if that works? I'm leaning more towards the opportunity of streamlining that process and maybe making the use of antidepressants more rational. So if we really believe that it is a huge problem and has a huge burden of disease, probably we need to treat it as such and not just dispense medications with very limited documentation.
Okay, down to our last couple of minutes here, and I want to try, let me try this with you, Tam, and again, to get a better understanding of how your life works. Is it more often the case that you have a patient come to you and say, I need meds, or is it more often the case that a patient comes to you and you want to put them on meds and they say, not interested?
So amongst my depressed patients, the vast majority of them do want medications.
Okay, and they are good candidates for that medication?
They are, but I always feel that it has to be couched in having other available resources as well.
Okay.
So if the expectation is that the medication alone is going to provide relief or improve their symptoms in a short period of time, then that's not a reasonable expectation.
And is the expectation that once on this medication, they'll be on it for how long?
I always say at least 6 to 12 months. And that,
6 to 12 months.
And that we reevaluate this at every given opportunity.
Okay, and after 12 months, again, more often than not, are they staying on the medication or getting off it?
So it also depends what else is happening in their life. So if they got fired from their job, or they got divorced, or their child's struggling, then that's something that I'd be more reluctant to stop.
We had a good long conversation about this tonight, and I got the feeling we've scratched that much of the surface of this. This is such a complicated issue, but I'm grateful to all three of you for coming on to TVO tonight and helping us with this. John Ioannidis at Stanford University's Meta Research Innovation Center, Sydney Kennedy, St. Michael's Hospital, and a professor of psychiatry at U of T, Tamina Eapen, again at U of T, and a psychiatrist at CAMH as well. Good of all of you to join us on TVO tonight. Thanks so much.
Thank you.
Thank you.
Thank you.
The Agenda with Steve Bacon is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.